Good afternoon, everyone. So thank you very much, Professor Leblanc, for having accepted to be the speaker today. I will introduce you a little bit. So you describe yourself as a pediatrician and hematologist. So you are really, to me, an example that we need hematologists in the field of non-malignant disorders, but that we can always count on very committed pediatrician. You are Associated Professor of Pediatrics at the University of Paris-Cité and head of the pediatric side of the National Reference Center for Constitutional and Acquired Bone Marrow Aplasia, as well as the Reference Center for Autoimmune Cytopenia in Children. You work at Robert-Debré Hospital and has a part-time job in Saint-Louis in Paris. You have also research that is part of your life through your attachment to the INSERM units U1342 of the Saint Louis Research Institute. Your expertise is certainly in the field of DBA. I invite everyone to read the recent publication on gene therapy and on an international consensus statement in this field, both for which Thierry Leblanc is co-author. So I give you the floor, and thanks a lot.
Thanks a lot for a nice introduction. So I'm going to share my slide. Up. So I have nothing to disclose. Just in brief, DBA, it's a rare disease. We don't know actually the exact frequency because maybe we have more and more atypical cases, and these estimations are quite old by now. And on the other hand, we may have a reduction in families because of, for instance, prenatal diagnosis and so on. It's the main cause of constitutional erythroblastopenia. It's a model for ribosomopathy, and it's a genetic disease. The transmission is mostly autosomic dominant, but it's not so simple because we have many de novo cases. We have a problem of silent carrier, and I will speak about that. And we have also a few examples of autosomic recessive and X-linked transmission. So the disease is very, very heterogeneous, both for genetic and for clinical aspects. So I will focus on new criteria for diagnosis, on current therapeutic approach, new option for therapy in the future, next future, I hope, and DBA patient surveillance with a special focus on cancer. Now, as you may know, we have a very recent guideline. It was a very long process and a job done with Martin and me, and also my colleagues from New York, Adriana and Jeffrey. And we decide, the panel expert decide to change the name to DBA syndrome, mostly because we have more and more patients with DBA who are not anemic. So it's a kind of tricky name to speak about anemia if anemia is not present. So we decide to speak about a syndrome. We have now new criteria for diagnosis, especially if you consider the previous guideline, which were quite old. We have new recommendation for transfusion, chelation, steroid, and graft. And also new recommendation for surveillance, especially for cancer. So when do you have to think to DBA? Actually, in many, many different circumstances. Obviously for abnormal blood counts, but you may have patients with genetic defect in DBA genes and no anemia, or eventually only a mild anemia or isolated macrocytosis. Neutropenia is very frequent, and you must accept the diagnosis of DBA in front of a patient with frank leukoneutropenia, and neutropenia may be even severe for some genetic subgroups. You have obviously the typical case, the infant with very severe anemia and so on, but you have very, very different patterns. One thing to keep in mind is in most of the patients, platelets are completely normal. For instance, you may have a patient with 9 grams of hemoglobin, very high MCV, frank leukoneutropenia, but perfectly normal blood counts. And if you see that in an adult patient, you have really to think to DBA. And thanks to genetic, we have now more and more cases coming from different parts. For example, geneticists. We have a child with no anemia but congenital anomaly. They do a genetic test, and finally the diagnosis is DBA. You have some patients present with immunodeficiency. We may have very severe complication during pregnancy. We may have cancer in patients, and the cancer are unusual because they are more early than in the general population. The genetic pattern of the cancer is not classic. In most of the cases, cancer and DBA are severe in presentation, and the patient may have very severe toxicity of chemotherapy because it's an overall bone marrow failure. And when you give chemotherapy to a DBA patient, you may have severe anemia, obviously, but also cytopenia. And in adult patients, a very difficult situation is MDS features in a quite young patient. It may be either DBA per se or really a clonal evolution towards MDS or eventually acute myeloid leukemia. So regarding diagnostic, we now focus mostly on genetic, and it's more easy than in the previous guidelines. You just, if I can say, need a variant in a non-DBA gene, class 4 or 5, and a clinical and hematological presentation, which is okay for DBA. And this includes patients with no phenotype at all, actually. We don't want to speak anymore of silent carer because we know this patient with only the mutation, for instance, the parent of a child affected with DBA, this patient the parents may one day have anemia, may one day have cancer, may have and become with clinical feature of DBA. So there is no phenotype at a given moment, but the patient is still at risk of the same complication of any DBA patients. We have additional findings which are supportive. So you have the typical infant with erythroblastopenia. Obviously, you may have a rise in erythrocyte ADA activity, but you must check this before any transfusion. It's not always easy in patient. You may have elevation of fetal hemoglobin, which is classical in every inherited bone marrow failure syndrome. You may have a positive history. We may have more or less specific congenital abnormalities, and eventually you can study the rRNA processing. So you know DBA, it's a ribosomopathy, the first model of this class of disease. And in DBA, actually, you have a defect in the ribosomal RNA maturation. And if you look at the RNA species, you can suspect the gene involved in DBA. In the current guidelines, if you look at the supplemental data, which are very, very large and which may really help you in the management of patients, we distinguish three types of genes. The DBA syndrome ribosomopathy, that means the gene is involved in ribosome biosynthesis, sorry. So you have RPS gene and RPL gene. And we have also genes which are not protein, which are part of a ribosome, but protein involved in the biosynthesis of ribosome, like chaperones. And we have two examples of that, TSR2, it's an X-linked disease, and ETR3, it's an autosomic recessive disease. We have what we decide to call a DBA syndrome over, and it's GATA1 and TP53. To be honest, GATA1 is a kind of discussion between European and American. Most of the European experts do not consider that GATA1 is a part of the DBA syndrome, but Americans do. And for that reason, we keep, and we can say that there is at least something in common in the pathology of the disease. Because we know now that in every DBA patient, we have a reduction of GATA1 transcripts. So it's a kind of link with GATA1. And in a patient with gain-of-function mutation of TP53, you have an hyperactivation of TP53, and this is a common feature in any DBA cells. We have then candidate gene. That's we did find some variant of these genes in DBA patient, but at the moment, there is no functional confirmation to say that the variant is causal. So they are still on study. And we have phencopies, ADA2 and EPO. And in both diseases, you may have erythroblastopenia, but the pathology is very different and it's not ribosomopathy in that case. So if you look at the frequency of the genes, the most frequent are RPS19, RPL5, RPS26, and RPL11. And if you look at the genotype rights, among registry, we are more or less about 70% because in every registry, we have patients lost to follow-up, we have very old cases and so on. So we don't have a complete genetic study in every patient. But for a new case, by now, you can expect to get a mutation in 85-90% of patients. We have more genes to find. Well, we cannot exclude that some RP genes will one day be classified as bona fide DBA genes, but it will be genes involved in a very, very little number of patients. You may also find some other genes encoding for protein involved in ribosome disease like TSR2 and ETR3. But I do think that for most of the patients, actually, the genetic defect is within a known gene, but with a different mechanism of inactivation of the genes. And this is a very nice paper of about 2 patients. And these patients were claimed to have no genetic defect in the RPS gene. And when they go back to the whole genome sequencing data, they finally found 2 variants which were responsible for the DBA and in non-DBA genes. So I think this is the next challenge, will be to finally identify the variant in some patients for whom we don't have any gene. And my feeling is that in most of the cases, you will find variant in known genes and not in new genes. We can diagnose DBA without genetics. We did that for many years before the discovery of the gene. So you have a few biologic tools which may be useful. Typical bone marrow cytology. So obviously you have erythroblastopenia only in patients with very severe anemia. If you have a patient with no anemia or mild anemia, you will not have erythroblastopenia. There is no dysplasia on red cells. My feeling is we may have dysplasia on granulocyte lineage, especially in adults, but we have very few data on bone marrow analysis in adult patients. And the megakaryocyte lineage is generally normal. And the marrow is rich, it's not a poor marrow in most of the cases. You have elevation of ADA, once again, fetal hemoglobin, and ribosomal RNA processing study. We have a few studies. This is one from the Italian group. It may be a very good tool to confirm very quickly a diagnosis of DBA and to have a kind of orientation of gene involved. But at the moment, it seems to be very difficult to put this in the clinical setting, in the hematology lab, and we have data for a long time, but not in the current practice. You have to exclude parvovirus Benedictine infection, especially in infants that have syndrome, because the clinical syndrome may be very severe, and eventually over inherited bone marrow failure syndrome, in most of the cases, it's very easy. So once again, many different diagnostic situations. If I focus, for example, in adult patients, we have example of patient treated for pure cell aplasia. We are not responsive to immunotherapy, and finally, at the end, the diagnosis is DBA in an adult. The same kind of result in if you have myelodysplastic syndrome in a young patient, especially if you don't have any clonal evolution at karyotype or NGS, it may be inherited bone marrow failure syndrome, including DBA and so on. And once again, thanks to genetic, we have more and more atypical cases, and DBA is always more diverse. What are the therapeutic options? To that, we are still relies on steroids, transfusion, transplant, and eventually leucine. At a given time, about 20% of DBA cohort of patients are free of any treatment. We speak about therapeutic independence. We don't want to speak about remission because it's not remission. The patient is still affected with DBA and he may still become anemic in the future, but they may have no treatment. In adult patients, no treatment is not the same thing that normal hemoglobin level, because some adult patients are okay to live with 9 grams of hemoglobin, for instance. They are anemic, but they prefer to live without any transfusion support or steroid. EPO is not active, so sotatercept is not active. Vitamin B9 and 12 are not useful. Because of macrocytosis, many patients are on folate or B12. There is no use for that. And in the next future, we may opt to have some small molecules. Eventually, luspatercept, I will speak about that, and gene therapy. In a very patient, actually, the treatment may change with time. For instance, we may have an infant with typical erythroblastopenia. He will be on transfusion for 1 year, then he will be on steroid, and if he's lucky enough, he may stay on steroid with very low dose for a very long time. Then he may get therapeutic independence, and we can stop steroids. Then he may have a kind of relapse at the adult age, and so on. So the treatment varies according to the age of the patient. And we have additionally specific complication in adult patients, including the anemia of pregnancy, which may be very severe, and also cancer and hematological malignancies. So for transfusion, the main change we have in the new guidelines is the threshold of transfusion. We ask to maintain hemoglobin level at least to 9 grams per deciliters. I don't know if you look at the thalassemic data in the blood recently for the Italian groups, and they have a very strict correlation between the level of transfusion and death. The survival is different according to the threshold of transfusion at 5 years. They have patients transfused at 9, 10, 10.5, and so on. And the more the threshold is high, the less the patient is died at 5 years. So maybe 9 grams is not good enough, but it's really the minimal, especially in childhood, in order to have normal growth and development. And for a reason which is not very clear for me, patients with DBA do need more red cell than other red cell disease. For instance, in my adult patient, the typical burden of transfusion is 3 units every 3 weeks. It's much more than the standard 2 units every 4 weeks. Regarding chelation, we are also much more strict on control of chelation. The goal is to have ferritin below 500 and to have a normal MRI liver status, that's less than 3 milligrams per gram, and normal, obviously, cardiac status. This is difficult in DBA patients because we know that with the same level of transfusion, the iron overload is much more high in DBA patients, maybe in part because they don't have any erythroid lineage in the bone marrow. And for that reason, we have to be very strict on chelation therapy. We have to start very early, eventually in infants, which is not so easy because most of the chelator agents are not licensed for use in infants. And in children, adolescents, and adults, very often we actually need a combination of chelation if you want to really have a good result on overload. Desflurane is known to have a very high risk of agranulocytosis. It is 1% in thalassaemic patients and 10% in GBA. Nevertheless, you can use it, but only in third intent. And we recently published the French data on that. And in 90% of patients, it may be really of help. Each time I see a patient with a very low control of iron overload, the patient told me the same thing. I never see a doctor for my chelation. I see the doctor only for transfusion. So they give me the transfusion and bye-bye, and nobody really cares about that. And if you want to have a good control for this patient, you need dedicated outpatient visit. The patient came for transfusion one day and came another day to see you every 3 to 4 months, and we give them the way you explain him how to control iron overload. You know, this is an example of patient I saw in Hôpital Saint-Louis. It was an adult patient, and as adolescent and young adult, she stopped any chelation. So the situation was very severe, you know, 5,000 of ferritins, and the leak is about 20. And you see at the end, leak is very low. Leak is normal. It is possible in DBA patient, but you have to adapt every 3 months the treatment. You have to be very strict on that. And if you do well, and if the patient do well also, obviously, you will have a good result. Regarding steroid therapy, we still don't know really why steroid may be so active, but it is very active in many patients. The consensus is to start steroid only at the age of 1 year. Eventually, maybe later, if a patient is very small and if there is no problem with blood support. And we start at 2 milligrams per kilogram. The maximal dose in adult or in adolescent eventually is 80. And when you have a good response, just like iron for iron anemia, that means at day 10, 15, you have a frank rise of reticulocytes. And as soon as you have this rise, you can decrease the dose of steroid. And at the beginning, you decrease by 0.5, and then you decrease more slowly. In the past guidelines, we said that the maximal dose was 0.5, but it's very toxic. We decreased to 0.3. Some experts wanted to decrease to 0.2. But for the moment, the consensus is you may keep a patient on steroid if the dose is lower than 0.3 milligrams per kilogram. In practice, you have to be aware that DBA is really unique because there is no other disease in medicine in which you give steroid for 50 years, and there is no other disease in which you give steroid at very, very low dose. So the goal is to define the lowest active dose, and at best it should be less than 0.15. And we have a feeling that it's not so rare to have a loss of response in adult patients, but we don't have many data for that. If you look at the profiles of response, you have the very lucky ones, very cortical responsive patient. I have patients with 0.05 milligram per kilogram per day with 13 grams of hemoglobin. So strictly normal blood counts with homeopathic dose of steroids. You have patients who are responsive, but who need a dose between 0.2 and 0.3. And actually, this is very toxic at the long term, especially in children. It may be discussed in adults, but in children is very, very toxic. And moreover, these patients have both a very high dose relatively and a very, very limited response for hemoglobin. They are within the 8 and 9 grams of hemoglobin. So they are both anemic and with a side effect of steroid. In my practice, I consider that it's too much to be given for a long time. If you need more than 0.3, there is no hesitation. You have to stop treatment, and you can stop treatment very quickly in 1 week. And we have about 20-30% of patients who do not respond at all to steroid. So if you consider, of course, for instance, of children, at least at the end, you will have about 40 patients, 40% of patients on transfusion and 60% of patients on steroid. You have to discuss at any time, is it better for the patient to stay on steroid or to go back to transfusion? Leucine, the first treatment with Leucine came from Czech Republic, and we have one patient who did respond well to this treatment, who are free of transfusion after Leucine. We have only one clinical trial, it is this one. It was been done in 43 patients, mostly children. The very good point is we have a growth acceleration is about 40% of patients, and as the growth is a very big concern for children with DBA, this is a very good point. On the other hand, the hematologic response was very limited. You know, we have only 2 patients who reach therapeutic independence. That's they are free of transfusion, but one with quite low hemoglobin range, and 5 patients with a rise in reticulocyte, but no significant impact of hemoglobin. So the chance to have a true hematologic response is maybe only 5%. Okay, we can try, but it's only 5%. But for children we are still young, it may be of clinical value for the growth. So we can say it's cheap, it's non-toxic, it's given a traveler dose. So in children, in my practice, I give Leucine to every child. I explain the parents, and if they are okay to try, okay. I try in every child. And some parents told that the general condition is better, that the appetite is better, that the child is less asthenic, and so on. Maybe the result is not so good on the hemoglobin level. You have a kind of positive effect on general stature. In adults, okay, the problem of growth is no more, but you may improve general stature, and some patients do like Leucine, and they feel better with Leucine. Once again, it's not toxic. The open question is, because we don't have really data on that, is Leucine may improve response to steroid? My feeling is in the future, maybe we will use combination of different agents and maybe a kind of cocktail, and this cocktail will improve hemoglobin. So why not to try Leucine in adult patients also, especially for patients on the steroid therapy. Regarding transplant, the big change of these new guidelines is that we are okay for unrelated plant transplant, but with a very well-matched patient, 10 out of 10 donor, very well-matched donor. So we try to do the graft early in childhood, before 10 years, at best between 2 and 5 years. And the classic indication is a patient who require chronic transfusion, so a patient non-responding to steroid. We may have some patient very difficult to manage with very severe iron overload, and why not? But I'm not really convinced by that, because I do think that you can have a good result. The only exception may be if you have intolerance, major intolerance and side effects to chelation agents. And in adults, it's mostly for clonal evolution. So in practice, this is the result we have in France and Germany. You know, we confirm the impact of age. And if you look at the most recent transplant, the chronic graft failure, graft GVH-free survival, you know, is 94%. So the results are quite good. And I think if you have a child not responding to steroid, or we need a too much high dose of steroids to have a good level of hemoglobin, you have to plan the transplant as soon as possible, at best, once again, between 3 and 4 years. the limit of 10 years, it's the same limit in one Italian study and in the French and German study. The results are better in young children, but obviously there is no absolute rule. If you have a patient of 12 years old with a very good donor, very good condition, and so on, eventually you can detect. For adults, it's much more difficult, and each time a patient asks me to be transplanted, and each time I refer this patient to my colleague of a graft unit, the colleagues say no, because they consider that the risk is too important in adult patients. So maybe the only indication is patient with clonal evolution. Regarding gene therapy, I think GBA is actually a very good disease for gene therapy because first, the bone marrow is rich, is very different situation than in Fanconi anemia. We suspected that the hematopoietic stem cell collection should be not a problem. It's very attractive in adult patients who are not fit for allogenic transplant because it's a much less risky approach. And lastly, any partial result will be clinically valuable. If you have a reduction of transfusions, you will have also a reduction in iron overload, and the condition of the patient will be improved, even if the result is not perfect. The problem we have is many genes. So obviously, the patient who are mutated in a very rare gene, less than 1% of the patient, I don't know if they will have one day a gene therapy program. There is also a specific difficulty in DBA. We have an haploinsufficiency, so we need to correct 50% the level of a protein. And if we correct too much, it's not good for the cell. If we correct too less, not enough, it's not good for the cell. It's a kind of tricky situation. It's not like hemophilia. You know, in hemophilia, if you have a very, very low amount of protein, it's good enough to avoid any severe hemorrhage. In DBA, we have to correct exactly the level of the protein, but we can do this. And the problem is bone marrow is rich, so we will need a myeloablative conditioning regimen. You know that currently in Fanconi anemia, they give a corrected cell without CR, but in DBA, we will need a myeloablative conditioning regimen. Saying that, we did apply and we were granted by the European Joint Program for Rare Disease. It was a EuroDBA consortium. The lead was our Spanish friends in Madrid. And we just published that. And we did the job. That means all the preclinical requirements before to start a clinical trial. So we were able to show that the hematopoietic stem cell reservoir was not so poor in DBA. 2 vectors were developed, and if we look at in vitro study, the vectors were able to correct the deficit for ribosome biogenesis and for erythroid differentiation. So we are now ready to go for gene therapy, at least for RPS19, at least in Spain. So where do we stand? At the moment, there is no clinical trial activity. Maybe at the best, the Spanish group will be able to start within this year. Next year, we will have at least 3 clinical studies, all for RPS19. If you are very optimistic, that means maybe we will have a product on the market within 4 years, 4 to 5 years. For other genes, the group in Madrid, they did the job also for RPL5, which will be the next one. And there is a US group who decided to work on GATA1 because they think, and they have data for that in vitro, that if you overexpress GATA1, you may reverse the DBA phenotype. And there is a talk was given at ASH 2 years ago, and we have now the paper, nice paper. So maybe it will be an option. A very good point, obviously, but this will be able to cure any patient, whatever the gene involved. So if you are very optimistic, it's a very good choice. So what to tell your herpes 19 patient, because we have this kind of question, obviously. If you have a child with a good indication for transplant and a good donor, I said to the parent, do not wait for gene therapy because we don't know if it will be successful. We don't know when this will be available. And lastly, I guess you are aware, but for thalassemia and sickle cell anemia, actually it's not possible to treat an European patient with gene therapy because the price asked by the pharma is so high that the European authorities didn't give the access to these drugs, to this medication, to the European market. So it's very disappointing for patients, but this is life. For adult patients, you can say, okay, maybe you can wait. It's not, you can stay on transfusion, but if you want to be treated one day with gene therapy, you need a very good control of iron overload, because it will be a prerequisite data before to go to a yellow ablative conditioning regimen, which may be very toxic in patients with very severe iron overload in the liver. So it may be a way to get a good adhesion of the patient to chelating agents. Do we have new drug? The good point is if we have now many cellular and animal models, so we can do drug screening, and many groups work on that. And we have different compounds. We are on study at the moment, but only at the preclinical stage. You will have, I think, in September, I am the PI of this study. We will have a trial with luspatercept. So it is for a group of rare anemia. It will be for CDA, for sideroblastic anemia, and the BMS Pharma want to expand the number of disease. So we decide to treat some DBA patients, but very selected patients. That means not patient on transfusion, because I don't think that luspa may be of help in a patient with erythroblastopenia, but patient with low level of hemoglobin, either spontaneously or on steroid. So the study will be open in France and in Italy. And lastly, the only clinical trial we have at the moment is with bitopertin. So we know that there is a toxicity of 3M in DBA. You know, as we have a defect in protein synthesis, we have a defect in globin chains, and we have a relative excess of M, and 3M is toxic. And you can read this review we did with Lydie in Blood, and this is a fact. We have a drug which was developed at first for psychiatric disease, bitopertin. So it's a very well-known drug, and this drug is able to inhibit the GLI-T1, which is a transporter for glycine, the first step of the M synthesis. So the idea will be to limit the synthesis of M in order to not have this toxicity of 3M. So 2 years ago at ASH, they showed us the preclinical study and the design of the study. We are also data to say that bitopertin may be active in a thalassemic mouse model. And so there is currently a clinical trial in the US for DBA adult patients. Not responsive to steroid, which will be a dose escalation study. The drug will be given for at least 32 weeks and up to 32 months. And so at the moment, we don't have any data on that. Just the clinical trial just begin. And in brief, because I don't have so many time, about surveillance in children, the most important is growth. And we have a possible intervention, either to stop steroid for 2 to 3 years and to give to put the patient on transfusion in order to have a puberty growth acceleration normal, or to give gene therapy, and we have some data in DBA patients. And in adults, we have to screen for hypogammaglobulinemia, for cancer, I will speak about, and pregnancy management is also a problem. We know now from data from the US registry that there is a very high risk of cancer in DBA patients. The excess of risk is about 5, comparing to the general population. And the 2 solid tumors for which the patients are more at risk as osteosarcoma in children and adolescents mostly, and young adults, and colorectal cancer. And colorectal cancer, the risk is very, very high. This was confirmed by a second study from the same registry. As you can see, the median age at first cancer was 45 years, and the cumulative incidence was 40%. And in the current guidelines, we give guidelines for cancer surveillance, and we ask for colonoscopy beginning at the age of 20 years, every 5 years. So it's a big change in the management of patients, and we ask for that. For MDS AML, we ask for blood counts every 3 months, whatever the status of the patient, including for patients with no phenotype, and to do a bone marrow analysis only in patients with worsening of cytopenia, or obviously if you have blast in peripheral blood. We don't know at the moment if there is a benefit associated with sequential NGS analysis on blood samples. Just a story about a DBA patient. This patient was actually a physician. She was in therapeutic independence, rectal cancer at the age of 49 years. The chemotherapy was more toxic than expected, especially for red cell, and she was put on a transfusion on a regular basis in order to get chemotherapy. She had a surgery, but at the end, they decided to stop chemotherapy because of persistent thrombocytopenia. And she had only 2 cycles out of 6 cycles of FOLFOX. Unfortunately, the thrombocytopenia persists, and we do a bone marrow aspiration. There is only 1% blast with multilineage dysplasia. As you can see, the karyotype is just awful, very complex, monosomics, and so on. There is a mutation in TP53. The patient received the graft. She relapsed 6 months post-graft, and then she progressed with overt acute myeloid leukemia. So we have to detect this early, but maybe it would be not enough in any patients. And the second story in adult patients, she was a DBA patient, a young woman, herpes-19 mutated. She was on steroid during childhood, but then she was in therapeutic independence with very mild anemia, and finally she was lost to follow-up. Pregnancy, the hemoglobin was much more lower than usually. So they go to see an hematologist with, unfortunately, who is not really aware of the risk in the DBA patient. So I see her only at 23 weeks of amenorrhea. I put her on transfusion immediately, but as you can see, the outcome was at the end very poor. She had a toxemia, which is a very classical feature in DBA patient during pregnancy. And for the fetus, the story was also sad, with a very limited growth, severe anemia, and the fetus received in utero transfusion, but at the end, fetal death. So if you have a patient who want to be pregnant, you have to anticipate this. She needs a very good maternity. She needs to be put on transfusion and eventually to be put on aspirin. So in conclusion, because time is running, as you can see, DBA is very highly polymorphic and may present in many ways. We have now very precise recommendation, and I urge you to look at the supplemental table because the manuscript was about 15,000 words, and Lancet Hematology wanted only 6,000 words. So it was very difficult for us to reduce the manuscript, and we put many things in the supplemental files, which may be very useful for you. We need to improve the diagnosis, the follow-up, and the management of adult patients, and we have currently very limited data in adult patients, and we may hope for new therapeutic approach in the medium term. Thank you for your attention.
Thank you very much, Professor, for your comprehensive presentation. As mentioned earlier, we'll have a Q&A with the professor himself right now, so this is an excellent opportunity to ask questions directly through the chat to the professor. And perhaps while you're doing so, we can start off with a question from our moderator, from Beatrice. The question is, elevated ADA and elevated HbF related to the upper limit of reference values. What should we expect? Slightly elevated levels or more? How do you rely on those tests?
Well, regarding ADA, we don't have so many diseases in which ADA is above normal value. So we consider that any value above usual value is of significance. Obviously, it may be lower if a patient had a transfusion recently. So in that case, it's not possible. You may also test ADA in parents, and in some cases, we have a very high ADA level in one parent, and this is very suggestive of diagnosis. So for us, it's a very good tool, but it's not so easy to perform, especially because we have to do this before any transfusion. For fetal hemoglobin, it's not specific at all, but if you have a red cell disease and with high level of hemoglobin, or fetal hemoglobin, this may suggest bone marrow failure syndrome. And if you have typically red cell disease, it may be DBA. So after the age of 6 months, you should be less at 1% of fetal hemoglobin. If you have 3, 4, 5, okay, it's okay. This is the first point. The second question is, do we need other molecular techniques to make a diagnosis of DBA? I think clearly, if we have the data of whole genome study, it may be of interest to have a second look by a specialist of the disease, and maybe it will be more easy for him or her to suggest a problem. But in many cases, we have a variant of uncertain significance. So the next step is to validate the variant, and we need a functional study. So I'm not sure we need really more molecular techniques, but we need more approach to validate a variant we suspect. This is the main challenge. And lastly, at first we look only for the coding region, then we look for the entrance. Now we look in the very upstream of the genes, and maybe we can suspect that if we have long-range analysis and so on, we will get more diagnosis. Just to say, it's not. Sometimes we need a second look.
Great, thank you very much for your answers to both of those questions. Just as a reminder, this is an excellent opportunity to ask Professor questions now. This is the concept behind the Thursday webinars, the cutting edge and having such experts available. So if you have a question, please place it in the chat. In the meantime, I just wanted to make a small announcement that we have upcoming Thursday webinars on July 3rd and July 10th. I'll put the link in the chat for those that can join. And as you may have understood, this webinar is being recorded, so it will be available on our ERN-EuroBloodNet YouTube educational platform. And so perhaps I will ask one last time if there are any remaining questions for Professor Thierry Leblanc. And if not, I would like to thank you on behalf of the ERN for your time and your expertise and for your many contributions to the ERN and hematology itself. And it's been a true pleasure, and we look forward to future collaborations. And thank you all to the audience for joining today. It's been a real pleasure. So have a wonderful afternoon, and thank you once again. Thank you, Professor.
Thanks, Evan. Bye-bye. Bye, everyone.
Pleasure.
Thank you, Thierry. Bye.
Thank you.